on. Fine. And what actually happened is that the ventral abdominal hernias and workup and management, we are going to discuss about it. So let's discuss about first of a few cases. Fine. So what do you intend to learn from this? So we'll just be going on small recall of the anatomy of the anterior abdominal wall and common points of weakness in the anterior abdominal wall. That's what we're going to discuss. And recall reasons for development of hernias. It's not inguinal hernia. Sorry, this is a misprint. It's a development of ventral hernias. And then we'll choose appropriate investigations to plan for surgery. Fine. So, and what are the different approaches? Just brief. We don't want you guys to go in details of how in depth we need to go for management. Just the basic principles you need to know. Fine. And then in the last, you need to know clinically correlate the findings and investigations with the choice of operation. Fine. So you guys remember this from your second year, and this is one of the things that you guys need to know. Fine. Can anybody this fine, you guys can hear me? If you hear me, can you raise your hands, guys? Raise your hand from the option so that we know. Okay, yes. Hadika, so fine. We have people raising it. Fine. So fine, great. So two people have raised their hands out of 62 or 63. So I presume these two are listening to me. Yeah, thank you. So what we are seeing is the anterior abdominal wall from the inside. Fine. You can actually see that they are, if we take a cross section, this is the abdominal wall from the inside, and you can see medially there is this line coming in from all the way from the diaphragm downwards, and this is called the linea alba. Fine. And linea alba is the centralmost point, and on both sides you can see the rectus abdominis muscle. If you see on the picture of your, on the right side of your screen, you will see that there is a thin line in between. That's the linea alba, and there is rectus sheath, the anterior rectus sheath and posterior rectus sheath. Fine. And rectus muscles in between, rectus abdominis muscles. Laterally, there are three muscles which are coming in: the external oblique, internal oblique, and transverse abdominis. So basically, this is above the arcuate ligament. Below the arcuate ligament, we cannot see any posterior rectus sheath. Fine. We just have anterior rectus sheath, and posteriorly there is the peritoneum. It's very much important that you guys know the anatomy, because we'll just see what happens in these patients. Fine. Sorry. So we'll discuss about the first case. We have a 53-year-old male presented with swelling at the level of the umbilicus, and he's complaining of pain at the swelling, and on examination it's 2 by 2.5 centimeter. There is positive cuff impulse, and there is no warmth or tenderness. If you look at it, what kind of a hernia do you guys think that is? Fine, you can write it down on your chat box. Fine, just write it down on your chat. Yeah. Yeah. This is umbilical. Somebody says this is umbilical, and somebody says this is paraumbilical. So we have two opinions right now for you guys. Abna, Dania, and Muhammad Tarek, Tanveer Ahmed. Good. You guys are taking part in it. I'm really happy. So we seem to have a bit of two groups. One is saying this is umbilical, and one is saying this is paraumbilical. So we'll come to the next group, and then I want you guys' opinion. So we have a 52-year-old male now. He is a known case of chronic liver disease, and he's presented with a large swelling in the anterior abdominal wall. Swelling is 10 by 8 centimeters in diameter. And according to the patient, swelling has been generally increasing in size for past 4 years. Now feels severe pressure at the site of swelling, and the examination is as follows. This is the swelling you guys can see. Fine. This is the side view. and this is from the front. What do you think this guy has? Paramumbilical hernia or umbilical hernia? Hmm? This is umbilical. So if we take this picture and we compare it with the previous one, fine. Realize this. Here, when there is a paraumbilical hernia, the umbilicus is not going to get obliterated. There will always be, it will be a rounded structure normally, but here it becomes slit-like. The one you know the emoji sign of happy face. That's what it looks like. Fine. There is a smiley right over here. Fine. You can see my pointer, and you can actually see there is a smiley right over here. So in paraumbilical hernias, umbilicus does not get obliterated, and you will see it becomes flat or slit like. It might be a smiley or it might be a sad face depending on where the location of hernia is. If it's above, the hernia is above the umbilicus, it will make a smiley. If it's below the umbilicus, it will make a sad face. But if you compare it with this one, here we cannot see any umbilicus. It's just obliterated. The whole umbilical thing is obliterated, and this is more of a umbilical hernia. Normally, we do not see umbilical hernias in elderly, except for people who have developed chronic liver disease. Usually, it's children who get umbilical hernias, fine, because of some development and abnormalities. We won't be discussing that because that's part of pediatrics. But usually, chronic liver disease patients can present with an umbilical hernia just like this, and you can see there is a very good transillumination in this patient. Very nicely, this patient has transilluminated. We have another patient. Now, this is a 38-year-old female, mother of two, and she has presented with a swelling in her abdomen. Now, I would like you guys again to tell me what type of a hernia that she might be having. Is it an umbilical hernia or a paraumbilical hernia? Okay, somebody says this is a paraumbilical hernia. Any other guess? Any person? Do you all think this is a paraumbilical hernia? Mariam Zahid, absolutely fine. Good. Now, if you guys look at it, when we say paraumbilical or umbilical, that is pertaining to umbilicus. In paraumbilical hernias, it might become slit-like or it might totally get obliterated in umbilical hernia. In this picture, do you guys see whether this is impinging on the umbilicus? Has the umbilicus become slit-like or it has become obliterated? Guys? Nope. Hadika, you're absolutely right. Nope, it is not. And that's the reason why this is not a paraumbilical or umbilical hernia. This is called an epigastric hernia. So any hernias that might be present between the umbilicus and xiphoid process, anywhere else, and they're not impinging onto the umbilical region, this will be called an epigastric hernia. So this is an epigastric hernia. So you need to remember these terms because there is some slight differences in management of these conditions. Fine. Next. This is another patient. She is a 77-year-old female, and she again came with complaint of painful swelling in the abdomen. You can see there is a small bulge over here. Fine. What do you think she has? This patient, 77-year-old female. She has come with a bulge. She has previous surgical scar right over here, and you can see there is a bulge right over there. Is it, first thing is it in the center? It's not in the center. It's slightly at the side of it. So what do you think this patient has? Okay, lateral hernia, fine. Does it have a special name? We'll come to it. Just keep it in your mind that there is a case, and we'll come to it later on. Fine. Okay. So now we have another patient. Fine. This is a female. She's a 45-year-old female, and she is a gravid at 10. She had 10 kids. Fine, and she has come to the OPD with swelling in the anterior abdominal wall. Whenever she raises her hands or tensing abdominal muscles like cuffing, raising her feet, you can actually see there is a huge bulge in the center of her tummy. What do you think is wrong with her? Fine. I've already let you guys in the answer though. Fine. So I'm going to ask you guys, what do you think is wrong with her? Fine. This is another case. Hmm. Can you guys tell me what's wrong here? It's in the center. Is it an umbilical hernia? Is it a paraumbilical hernia? Is it epigastric hernia? Or is it something else? Guys, can you hear me? Her rectus sheath is ruptured. Much close, but not very close. Linea alba is disordered. Now, this is a condition where I would like to ask you guys another question. I know a lot of you guys will be really angry that I'm asking you a lot of questions, but the thing is, what are the components of a hernia? Whenever we say that somebody has a hernia, we want to know what are its components. So can you tell me, guys, what are the components of a hernia? Guys, I'm waiting. Hmm. Yes. The components of a hernia includes body and the fundus, and that's exactly what we feel when somebody has a hernia. We try to make a wall. There is a wall, and then what happens is there is the neck of the hernia, and then there is the whole sac. The farthest part of the sac is called the fundus. Fine. And here there is no neck. This is the just the sheath which has expanded, and we don't have a hernia. This is called rectal diastasis. And this, what is the difference between divarication of rectal and ventral hernias? There is no defect here. The whole linea alba is stretched laterally, causing it to feel like there is a hernia, but there is no defect in between. And that's the reason why it is very imperative that whenever we are going to examine somebody, we're going to ask them to raise their head, and this is one of the tests that we do. We ask them to cuff, raise their hands, head or feet, and then we see a bulge, and when we palpate it we cannot see a defect, and this is called divarication of recti or diastasis of recti. Some of you guys have answered it very nicely. Fine. Mohammed Shah, you're absolutely right. I'm talking about not the contents of the hernia. We'll come to that, but what actually is a hernia composed of. And if I can have a whiteboard, can I have a whiteboard in Zoom? Moderator, please. If I can, then I would like to show these guys how we how what are the components of a hernia. Okay. So now we are going to go back, going forward, and we are going to do something else. And there are certain special types of hernias, and that are called incisional hernias. Incisional hernias usually occur after surgery, and it is very, very common in elective. About 1.2%. If there are 100 patients, about 1.2% will develop a hernia in elective surgery, and the chances of developing a hernia in emergency is 12%. And they usually appear on the 9th post-op day, and mortality from this hernias is 15 to 35%. So it's a very serious condition in emergency surgery, especially. Usually, these people will present with abdominal pain, tenderness, and vomiting. An incisional hernia occurs when, after wound healing, there is, although the skin has healed, but the inner fascia they do not heal, and that's the reason why there is a gap, and this results in incisional hernia. And it's about 10 to 20% of midline laparotomies which develop a hernia, and recurrence after repair is 23%. So if people who turn up to us after surgery and they develop a hernia, we try to operate, 23% of them will come back to us with a recurrence. So it's a very high number. Now, this patient had a surgery done, fine, and we made a stoma in this patient. This was an emergency surgery. Can you notice the bulge here, guys? Can you notice the bulge over here? Fine. You can see this is this bag, and you can see there is the whole bulge. And this is a special type of incisional hernia, and this is called parastomal hernias. These hernias, because we are bringing a loop of bowel out, there is a space which is directly communicating with the skin, so loops of bowel can come in between. Guys, can you hear me? I cannot see much in your chat, so I want to know if you guys are hearing me. Can you answer? Can you see this? Okay, good. So this is, now again, this is a special type of hernia. So whenever you go, guys are going to examine somebody's abdomen, always ask them to cuff. Always on inspection, see these findings. Like if there is a bulge coming out, if there is bowel coming out, and there is a bulge all around it. Fine. This is another picture which is much more clearer. You can actually appreciate this part of the abdomen. You can see how small or thin lean it is. There is a previous scar of laparotomy in middle, and you can see a huge bulge showing up over here. So contents of loops of bowel are outside the abdominal cavity, but below the skin. And this is very difficult to treat because this is a parastomal hernia. There are 25% chances of developing a parastomal hernia. Thank God we don't have it that much amount in here in Pakistan, but we are under reporting, so we don't know the actual figure. But in Western countries, 25% of the cases develop a hernia when you make a stoma. So, Mohammed, here is the question. What are the contents of a hernia? What do you see? It can be anything in the abdomen that will be a part of this hernia will also be can be a part of the hernia. For example, there is omentum in the abdominal cavity, so omentum can be part of this. There is small bowel can be a part of this. There is bladder can be a part of the hernia. Anything which is intra-abdominal can go into the hernia. Sometimes in children there can be even liver over here. So if you can see the picture on your left, what do you see here in this picture? Right over here, there is some fatty material. What do you call this? This fatty material. Fine. Can you guys tell me? Yes, this is omentum. Absolutely right, Minha. And omentum. And on the right side, on the left, you have seen. On the right side, what do you see here? What is this? These are bowel loops. Fine. So I have another picture for you guys, and you guys are going to tell me if that picture compared to this is that going to be enough for you guys. Fine. So I'm going to share something with you guys. Can you see this? Can you see, guys, this picture? What do you see here? Yes. What's the color of the bowel in this one? Do you see? This is also a hernia. In fact, this hernia was operated last week. The picture you can see in the middle. And what is the color of this bowel? Is it brown? Is it blue? Is it black? Okay, you guys cannot see the picture. Okay, let me see if I can share it. Uh, you're sharing your picture, and I thought I can share it with you guys. Can you see it now? The picture. I'll go back to the previous one then. Okay, what do you see? The color of this bow. It is normally it's pink in color, but here it is reddened and looking very dusky. And even if you look at it, it looks very shiny. What do you think is wrong here now? This is a complication. Fine. And this complication is telling us that there is an issue with the bow. Can you guys see it? Yeah. Hmm. Can you see the picture now? You can click yes or no in your answers, and I'm just going to see it. Fine. You still cannot see it. Oh, what's wrong? Yeah. Yeah. Yes, you can see it. Fine. So you can see the color of this, and it's very dusky color. Fine, right over here. And this is because this is a strangulated hernia. Fine. Holla and Afreen, good. You can see rest of the guys. This is a strangulated hernia. So this is one of the complications that we feel if we don't operate in the proper time, people can develop strangulation of the hernia, and that's why we need to deal with it. Fine. Here, this is the summary of the common types of ventral hernias that we see. And you can see we have umbilical hernias, paraumbilical, we have this epigastric hernia, fine. And sometimes we have something called a spigillate hernia, which is usually in the area called linea semilunaris. And that's one of it's very rare though, it's not that common. But the problem is it occurs in between the layers. So usually you cannot feel a lump like we did in the picture here. When we see this, usually the patient complains of pain and there is something wrong in their abdomen. On examination, you might feel a vague lump or you might not feel anything at all. So clinically, it's very difficult to diagnose. You have to have a high index of suspicion, and that's why anatomy is really important. And we have something called an incisional hernia as well. Fine. So these are the most common types of ventral hernias. So what are the factors that develop this hernia? So we can grossly divide it into two types. Fine. We can have patient related factors and technique related factors. Patient related factors, people who are obese, obviously, as this there is a picture of a paper that was there, and they saw that increased BMI people have more fat, and because of this more fat, intra-abdominal and intraperitoneal more fat, there is stretching of the linea alba, and that's why hernias form. Similarly, females who have high gravida, who are delivering child, constantly their abdominal wall goes into stretching, and because of malnutrition, there can be gaps that might form. Fine, that can result in either diastasis or a hernia. Fine, and there can be other conditions, congenital conditions like spigillin hernias. People can also have undescended testes. It's very unusual. So people who develop in spigillin hernias can also have a problem of descent of testes down. They might have intrapelvic or intra-abdominal testis. So how do I investigate? What investigation do you think we should do to find out that this person has a hernia? We have done the examination. The common examination is we stand at the foot end, we ask the patient to cough, and the bulge will come out, and we know, we try to palpate it, we try to palpate the margins and openings, and we see how big is the neck of the hernia. Fine. So clinically, it's a clinical diagnosis. Do we need to investigate it at all? Fine. Do we need to plan something regarding it? Okay, Afreen Arif, you're right. What investigation do you think we should be doing here now? Hola Anwar and Afreen Arif. Let me rephrase the question. What is the least invasive investigation that we can do in this patient? Least invasive investigation. Yes, we can do an ultrasound, and you guys can see. If you remember the picture I showed you guys earlier, this is the fat, this is the external oblique, then the internal oblique, and this is the transverse abdominis muscle. This thin line which is going in just below the transverse abdominis muscle, this is the peritoneum, and you can see the bowel over here. So it's a least invasive investigation. Fine. So you will see normally these laterally and medially, these are continuous, but look at this picture and you can see something is coming right over here and going in between bowel loops right over here. I'll show you another picture so you guys get an idea. See, this is the right leg rectus muscle. This is the this is the right leg rectus muscle. This is the left rectus muscle. We are sitting at the foot end of the patient. Fine. And we are seeing this patient from the foot end. So the head is on the other side. Fine. And here on my side is the foot. On my side is the foot, and on that side is the head. And you can see the left side of the rectus and right side, and you can see in between something is coming out. You can see this. Can you appreciate it? This is a hernial sac. Right? This is the linea alba. There is a defect. Now the size of this defect is very, very important. Why? Because the smaller the size of the defect is, the more chances are that the bowel pieces are going to come in and get strangulated. And that's the reason why whenever we are going to see these patients, we have to know what's the size of the hernial sac. We need to know what's the emergency. Can the contents go back down into the abdominal cavity, or is it stuck over there? What do we call if the things are stuck over there? It's called a incarcerated hernia. Fine. Sometimes bowel loops come in and they get stuck in here, and what happens is the patient starts vomiting, there is abdominal distension, and patient is unable to pass stool or flatus, and this causes intestinal obstruction. The other times, if we don't relieve it in time, what will happen? This swelling is going to gradually increase and rupture, and will result in perforation. Now, if you see this picture in the previous view, this one, you can actually see the color of the bowel has changed completely. If we would have waited another 2-3 hours, this would have become blackish in color, and then it would have perforated. So there will be gangrene of bowel and perforation, and it would have contaminated the whole field. And that's the reason why we have, whatever we do it fast. Otherwise, it's going to cause a lot of problems. Any other condition thing that we need to see is, now ultrasound is very much user dependent, and we cannot appreciate the anatomy as much as in this patient. See, here's, you guys can see CT scan. CT scan is very nicely delineating the anatomy. You can actually see the external oblique, internal oblique, transverse abdominis, and this is the rectus abdominis muscle. This line is called linea semilunaris, and this line is called linea alba. And this place where the pointer is, this is the place where we have a chance of developing a Spigelian hernia. Here in the midline, we have a chance of developing umbilical hernia, paraumbilical hernia, or epigastric hernia. So defects of the linea alba can result in other things. And in posterior part, again, where this is joining the rectus spinae muscle and quadratus lumborum, we have this area, there's a potential of developing a lumbar hernia on the back, and it is extremely rare. So this is the main picture for you guys to remember, that people can develop hernias in various parts of the abdominal wall. So I'm going to give you guys a small quiz. Can you guys see where the defect is? Fine. Can you see it? You can actually appreciate this is again the rectus sheath, and you can see the whole of the bowel. This is the transverse colon which is gone in. You can actually delineate the whole of the transverse colon and is gone down into the abdominal cavity along with it. It's passing through the abdominal muscle into the subcutaneous fat. And this is a person with incisional hernia. The picture is just to show you guys how clear it is. If we know the anatomy, it's really delineates the things very easily, and we can plan the surgery. Again, this is a picture. Can you guys tell me what type of hernia this is? These are the rectus sheath. This is the linea alba here. Here is this linea semilunaris, and these are the external oblique, internal oblique, and transverse abdominis, which is going and attaching to the anterior superior iliac spine over here. Do you see something on the left side? Here is the rectus abdominis. And what do you see here? The internal external oblique, if you compare it with this side, do you see this deficient? Fine. Can you guys see this? Yes. So this is again a Spigelian hernia. Good. Hola, you're absolutely right. This is a Spigelian hernia, and it is coming out of this area called linea semilunaris. So you can appreciate how significant CT scan is. And whenever we see it, it can also tell us whether there is strangulation, if the contents are small bowel, large bowel. So we can have a lot of information from the CT scan. Fine, but we only do CT scan in patients who we know we can spare few hours to get a CT done and see. If this patient is in strangulation and we need to take 5 or 6 hours just to get a CT done, we won't go for CT, we'll go directly for surgery. So how do we treat it? If this patient comes to you in the OPD, in the emergency, how are you going to treat this patient? Are you going to just go and operate on him? Are you going to see, advise him something? Fine. So basically, first thing we'll do, somebody has written Hadika, you have written NPO first, asked to use belt. Fine. So first thing that we need to establish is how big is the hernia? Is it a chronic thing, or is it has just happened in a few days back? Is it large? Is it small? Fine. So duration, size of the hernia, and from the size of the hernia, I do not mean the size of the bulge, but the neck where the bowel is originating. A lot of times, if the hernia is stuck, you cannot feel the neck, and that's why you need a radiological investigation to find out how big is the neck. Fine. So you will do all the investigations first, and depending on duration and size of the neck and the symptoms of the patient, you will plan surgery, whether he needs an immediate surgery or he needs a delayed surgery. If there is an obstruction, we need to operate as soon as possible, because this patient is going to go into strangulation, and then we have to even resect the bowel. Right now, we can just push the bowel back into the abdominal cavity and he's going to be just fine. So we see the patient depending on his severity of conditions, his symptoms, and size of the neck and duration. We plan surgery. So what type of surgery are we going to do in this patient? So previously, there are two options. Either we repair the edges if it's a small hernia, or we place in something called a mesh. Fine. And when we place a mesh, good, we put a mesh in. Fine. We can do something direct repair, which is called anatomical repair. We took sutures and we repair the edges. And the other thing is we can put a synthetic piece of plastic in between. And what it does is it creates a reaction. And because of this reaction, what happens is there is fibrosis of this area, and which covers this granulation tissue and cover the hole. Just like if you have a tear in your clothes, you put another piece of cloth and stitch it. Same thing happens with this mesh as well. So we want to place the mesh. So my question to you is, if we'll go back to the first slide, fine. We'll go back to the first slide. Fine. In the anatomy, where here would you like to place a mesh? If you look at the picture on your right side, there is linea alba, there is rectus sheath, there are three muscles. Where are you going to put the mesh in? In which layer are you going to place this mesh? Are we going to place it just beneath the skin, below the fat? It provides physical support. You're absolutely right, Osama. It'll provide some support, but the basic reason for it is cause fibrosis. And when fibrosis happens, this causes a reaction causing fibrosis, and that plugs the hole. It does not have that much of a strength in itself. Fine, to hold back the whole condition. It just provides certain support till fibrosis happens. Fine. Otherwise, we'll do it in a. So somebody said above the peritoneum. Good, Mohammed Shah, good, above the peritoneum, fine. So you are saying somebody said on scarpa's fascia, that is just above the linea alba, there is thin layer called scarpa's fascia. We put it onto the scarpa's fascia, fine. Why do you guys want to put it on scarpa's fascia, and why do you guys want to put it in a below the muscles? So I'm going to, sorry, scroll down again, and I'm going to go in and we talk about two conditions. Assume you have a beaker which is filled with fluid. Fine. On the right side of the screen, you can see the beaker there, and there is a cork which is coming from outside. We push the cork from the outside, and there is pressure of water which is constantly exerting a pressure. The water inside the beaker is exerting pressure on all the walls. Eventually, what's going to happen, if there is increased pressure, it's going to push the cork outside. On the picture in the right, on the left side, the cork has been placed on the inside of the beaker. Fine. The inside of the beaker has the cork placed. What do you think will happen when the water pushes it in on? What will happen then? See the picture on the left and picture on the right. Fine, good. Abdul Rafi, you are absolutely right. It will plug it more tightly. Hadika, you are absolutely right. So what happens is, when we push this cork from the inside, it is actually going to push against the wall of the beaker and become more tight. It will become more stable. And that is the reason why we have, initially we used to place the mash above the muscles. Fine. Now we are placing the mash below the muscles. So when we place muscles on the scarpa's fascia above, fine, what do we see? This is called an onlay mash repair. What is it called? An onlay mash repair. Fine. Sometimes we just put the mesh on the defect itself, on the edges of the defect. This is called onlay mash repair. Then what happened was, this condition developed, that we were placing the mesh below the muscles, and this is called sublay mash repair. And then after the advent of laparoscopic hernias, we used to put a laparoscope. We are putting the mesh from the inside. We are going inside the abdominal cavity and we are placing the mesh in. So I told you guys, what's the function of a mesh? It causes fibrosis. What's going to happen if we may place the mesh right over here on the posterior side? Because the bowel is here, fine, you can see the bowel here, you can see large bowel, small bowel, its liver over here, there is omentum over here. If I place a mesh in, what is it going to do? It's going to cause fibrosis and adhesions. So is there a way that we can avoid these adhesions? Because we are placing a mesh from the inside. I'm going to show you guys a video as well, fine, at the end of it. I hope it will play on this. Fine. Fariha, you said use something non-adhesive, and that's exactly what we do. We have something called a composite mash. One side, which is away from the abdominal cavity, it has a material which causes fibrosis, and the part which is facing the bowels and omentum, that part is made of another material which is almost inert. It might be made of biological material like the dermis of a pig or a cow, and that portion is inert. It does not cause a reaction. It tries to keep away the bowel till fibrosis takes place. Fine. And this is called a composite mash. We use something called a composite mash for a laparoscopic hernia repair. When we are placing the mesh from the inside, we place it a composite mesh. Fine. It's very expensive. It's about 50, 60,000 rupees. It's very expensive for the patients. And we usually cannot do it in general population who presents to us because it's quite expensive. So normally which procedure you think we might be doing over here, which is providing support? Okay. Mohammed Shah, which part do you want me to repeat again? What we do is, okay, I'll go from the start. So what we do is we place a mash. We either place mash above the muscles within the defect, or we can put it below the muscles. If we push it above the muscles, what's going to happen? It's going to cause fibrosis, but the chances of recurrence are always more because the abdominal contents are going to constantly push it just like the beaker of water. Fine. So chances of recurrence are more. If we push it below the muscles, fine, it is going to protect because it's going to push against the muscles. So it's always going to be strengthening the mash that we have put in. Fine. All of these conditions, we can use something called a proline mash because that causes fibrosis and it's away from the bowel. But when we place a mash inside the abdominal cavity, it is providing strength, but because there is bowel underneath, we need a composite mash, a mash which does not stick to the bowel. But again, on the other hand, on one surface, it's trying to provide attachment of the bowel to it. And on the other surface, there's going to cause more fibrosis. So it's called a composite mash. Just to let you guys know, this is not going to be asked in exam, just to get you guys to know what happens when we use this. Fine. Hmm. And then, so let me recap it. We have a very nice presentation. This is not again for you guys to remember it, just to get you an idea that we have created something called an algorithm regarding incisional hernias. So if they're small and clean, hernias do not contain anything, we do a laparoscopic repair. And during this repair, if we have an enterotomy, we have to do a sublay mash repair. Fine. If there is cross contamination, then we do something called a component separation technique. And you don't need to go into component separation technique. I'm just going to mention it in the end. So don't worry about component separation. Just that you need to know that mesh is placed. Mesh is the treatment of choice. Fine. And it's placed either above the muscles or below the muscles. And this is sublay mash is the ideal condition. Fine. Because it's above the below the muscles and it's away from the abdominal cavity. It's cheap. The, we have a patient. Fine. Here he has come with a laparotomy after gunshot and having progressive swelling here. Fine. I'm going to show you guys again another picture here. You see in this picture, fine, there is a very nice pink looking bowel. So this was a hernia which we did last week, and you can actually see some adhesions over here in this part, and you can see this whole thing is very nicely delineated. Compare it with the previous picture and you will see that that picture was very reddish in color and the bowel looked very glistening. Fine. And we have another picture over here. Fine. I'm going to show you another picture. What do you see here? This is again another hernia which contained large bowel. Can you see the picture which is, can you guys see the picture? Okay, Fariha Masood, fine. This is black. This is actually a necrotic bowel. This patient eventually developed gangrene, and that is the reason why we had to resect the portion of the bowel. Now we cannot place a mesh where this is gangrenous bowel, because if we place a mesh in here, it is going to get infected. There is a foreign body which is going to get infected. That's the reason why whenever we see a patient, we try to operate as early as possible so we can place a mesh. Otherwise, we cannot place a mesh, and there will be chance of recurrence, more chance of recurrence in this patient. Fine. Now, so we have again, depending on if there is contamination, depending on the size, whether there is symptomatic hernia, we try to push in a mesh in. But if it is not possible, we just need to do something called component separation technique, which you guys don't need to know at the moment. Fine. And what we are going to do is, I'm going to show you guys, this is a patient who has come up to us and he is complaining of, see this patient. This is a patient with a very large hernia. And these hernias, if we try to bring it together with each other, if we try to bring both the edges together, what will happen? It's going to be a lot of tension. When there is going to be a lot of tension, what's going to happen? There will be increase in pressure inside the abdominal cavity, and this will cause something called a compartment syndrome. So that's the reason why whenever we are going to deal with these conditions, there are special measures. This is not for you guys, this is for postgraduate studies. But just to let you know that when there are large defects, we do something called a component separation technique. Fine. So after this, we'll conclude a session. Fine. I am going to place a link on your on your group. Fine. If you guys understand what we were talked about. So first we talked about the anatomy. We talked about some of the presentations that we see. Then we talked about the causes. It can be patient related. If the patient is obese, if the patient is pregnant, if there is for any certain reason they have increased abdominal pressure because of constipation, fine, because of cough, the fibers stretch, and because of stretching, there might be a gap that forms in between, and that causes an opening inside the cavity. Fine. And because of this, what happens is that there is a opening which presents, and bowel slowly, omentum or bowel goes out. The content might contain only omentum, it can contain small bowel, large bowel, or it can contain other thing like urinary bladder. Fine. So we need to go in early, because the late it is, there might be chances of complications. We want to go in early so that we can place a mash in, and mash can be placed below the muscles, above the muscles, or we can do it laparoscopically by going inside the peritoneal cavity. If we go inside the peritoneal cavity, we try to do something called composite. We use something called composite mash. The reason for using composite mash is so that we can easily push in. We try to produce some fibrosis on the side of the patient, and after that, but we don't want the bowel to get attached to it, so the other side is inert, which causes it to be cleanly, easily not adherent to the bowel. Fine.
Time is up. 3 बज रहे हैं.
चलिए फिर बस मेरा ख्याल है कि काफी होगा. I've shared the link with you guys. Fine. And what I want you guys is, I have a student feedback form, and I want you guys to please kindly correctly complain or tell me if there was a problem with the lecture, there were some points that you wanted to be discussed more. Fine. So that we can discuss that here. And if you want to discuss something, you have my email, so you can write to me. Fine. Is that okay? So
Okay, sir.
I've shared my email address with you guys. You can just contact me up. Fine. At duhs.edu.pk. And kindly also please fill this form. Fine. The one I'm just putting around. All of you guys, please do it and do give us a feedback, and we'll change the way. I have access, so you have to allow access to slides. I have allowed you guys access. I'll see if I can change the access and then see. But I have everybody with the link can have the access to this drive. That's what I've done. Fine. Okay, guys. Okay. See you guys. Bye.